Any questions from the last lecture? So this is the last bit of content for this section of the class. Yes, woo. But you have like 3 more to go, so just a quarter woo, I suppose, is in order. So I may not be able to finish this section today, so we will try to finish it up at the next class session, and that will then lead into the review. So we'll do a little Kahoot review for you guys, and then that'll be the test next Friday, I believe. So that'll be that, and then that later on that day, right afterwards, you think you're done with physio. Guess what? Move right back into it. Get to do a whole nother lecture, starting with section 2, which I don't even know what's in that section yet. I gotta look at it again, but we'll figure that out together, right? Anyhow, basically what the first test is going to be covering up through this sensory information right here. So anyway, so today we're discussing physiology, mainly of your 5 senses, so touch, smelling, hearing, all those good stuff. Some people have a 6th sense. If you see dead people, then perhaps you may notice that. However, I will not be covering that one here, right? Some people have ESPN, but again, we're not going to be covering that here. Anyway, the first section, actually, we'll just kind of talk about sensory sense perception just a little bit here in general. But basically, there's kind of functionally different categories here we're going to talk about. One being chemoreceptors that are detecting what? Chemicals of some sort, absolutely right. So this can be chemicals in the environment, so things like smell and taste, or in some cases you may actually have receptors that are detecting chemical changes within the body, right? So that could be things like pH, it could be things like osmolarity, different things like that. We're going to have photoreceptors that are good for light, right? Perfect. Thermoreceptors, obviously cold and heat, and then some mechanoreceptors as well. Going to be good for like touching. Even hearing is going to be involved with this. We'll see how that works later on, like in the cochlea. But that is actually considered to be a mechanoreceptor, and we'll talk about, trying to think of the word, completely lost. I'll think of it later, but basically it goes along with the cochlea. It is our sense of equilibrium. Thank you so much for correcting me. Equilibrium, we'll talk about that as well, because that kind of goes hand in hand along with hearing, with the ear. Obviously, those are very closely linked together. So we'll talk about those as we get into detail. Moving forward. So anyway, so you can see the different categories that are here, and again, you can kind of refer back to this. We're going to talk about these in more detail. Does anyone know another name for a pain receptor? Yep, nociceptor would be one of those. It's not a yesiceptor, but a nociceptor, right? You don't have to laugh at those. That's fine. But these are the main ones we're going to be here, like nociception. That is basically the perception of pain that happens, which is a big deal, right? Because again, pain is going to be one of the most common things you're going to be treating. It's one of the most common reasons people show up at your clinic, right? Are going to be pain of some sort, whether it's acute pain, chronic pain, and how we treat that, how we manage that is going to be very, very important. So understanding what pain perception is going to be a big deal here. Now, with the nociceptors, these stimuli can include wide varieties of things. So you can have things like heat, obviously. So if you touch something like a stove that's on, yes, you're going to sense pain when you sense that heat. Cold can do this as well. In some cases, pressure, even chemicals. Can you think of any chemicals that can cause pain? Maybe like if you're cooking in the kitchen. And whenever like work with jalapenos or something, and you get so it's capsaicin. The capsaicin is one of the chemicals found in like spicy peppers that can cause pain, especially when you get it in contact with like mucous membranes and things like that. But we're going to see that perception of pain can be influenced by several things. Is there like an objective way to measure pain? Absolutely not. If you can come up with that, you're going to be a gazillionaire, because it'd be really nice if we could look at a patient and try to determine, whether through lab test or otherwise, are you actually in pain or not? But we're never going to be able to do that. So it's always subjective, and can be influenced by things like their emotions, can be influenced by expectations of pain. So for instance, like if you're really needle phobic and you have to get an IV placed, especially like little kids, that can really enhance their perception of pain, even though it probably isn't really that painful in the first place. So again, nociception can be a pretty kind of complex thing there. So looking at some other kind of sensory receptors, how about proprioceptors? What do they help us with? Is it pressure? Not pressure. Well, in some cases maybe pressure, but it's going to be more helping us to determine body position. It allows us to help with kind of fine motor control. So proprioception, usually you're going to find a lot of this located within things like the muscles, the tendon, and the joints, and it kind of gives our body a sense of what the muscles are doing, kind of what position they're in currently. And again, the really important thing here is all this sensory perception is going to be fed up into the brain, and usually with the thalamus, and it can be sent out to various places from there. And so you have to integrate all this information together. So information from the eyes, information from the vestibular apparatus, information from the proprioceptors, all have to kind of come into conjunction with one another. That allows me to stand up here and talk, and without falling over, right? I may fall over at some point, but hopefully all those processes are going to be working in tandem. I can say standing up, right? We'll have our cutaneous receptors that are normally found where? In the skin, absolutely. So that's going to help us with touch, being able to feel like textures, pain certainly, heat, cold, etc. And then we'll talk about our special senses later on in this section. We'll talk about vision, hearing, taste, smell, equilibrium, all that good stuff, right? So how do we actually detect these signals? Like, how does this stuff actually get transmitted up into the brain? Because we know it's going to be through the neurons, but how does that actually occur? How does that signal get sent from, say, the skin, or I say prick it with a nail or something? How does that signal get transmitted up to the brain through those neurons? The answer is action potentials, right? Oh man, action potentials already coming back. Remember those? Hopefully, no one blocked them out already, because they're going to come up again and again. So you can imagine here say like a free nerve ending, say located within the skin, say it's located in the epidermis there. And so what you're going to find is depending on the type of neuron that we're dealing with, the type of sensation it's going to be responding to, you're going to usually have these action potentials that are going to start to fire off. And that's going to send that signal, that sort of stimulatory signal, up to the neuron, up to the spinal cord, and usually up to the brain, where it can then be kind of processed from then on. And so depending on how often these action potentials are firing, how frequently they are, can really dictate like how big of a signal we're going to be getting essentially. And so in a lot of cases you can find, especially with like with touch, you're going to find a lot of these nerves here as they become deformed. So say for instance I'm like touching something and putting that pressure there, what you're going to find is you can actually cause distortion of this neuron here to where you can actually open up some of these channels. And we remember that with action potentials, normally a resting membrane potential is positive or negative. Usually negative, usually like negative 70 or so. And then opening up certain channels, especially what type of channels, what ion? Sodium is a big one, right? So by deforming this, you can actually cause that pressure to actually open up those sodium channels to allow the sodium to flow in, and that can then trigger off an action potential to occur once you reach a certain threshold there. And by doing that, that will then start to propagate a signal. And again, remember those nodes of Ranvier, we talked about how that helps to speed up movement of the action potential along the neuron. That can basically then propagate that signal up to the spinal cord to the brain to say, hey, there's pressure here, there's some sort of touch that's actually going on, some sort of tactile sensation. And so this can occur with either mechanical deformation, like in this case right here. So imagine there's like kind of pressure pushing up on here. You would have deformation of that neuron that allows sodium channels to open. Some cases it could be chemicals being applied to the membrane itself. So for instance, imagine smell. We're going to find that there's in the olfactory bulb, there's lots of cells that are there with these little cilia that respond to different chemicals coming up and actually activating certain things like, like G-coupled proteins and things like that, as we'll see. Could be temperature, could be electromagnetic radiation. What would be an example of electromagnetic radiation? Things like vision, right? Because again, we're getting this kind of radiation being sent into our eyes, and we can kind of respond to that. That light energy can be utilized to kind of kick off those action potentials, as we're going to see a little bit later on. So anyway, once the channel's open, you have an action potential, and then based on the frequency there, it will determine how much sensation you have. So if it's just a little bit of an activation, you may only get a few action potentials kind of happening here. So imagine you have the resting membrane potential of a nerve, and then once you hit that certain threshold, it may fire off, kind of slowly. You may get a small amount of perception of a sensation there, or it can happen much more quickly. And we're going to see that, depending on the type of tissue we're dealing with, this may change over time. So there's going to be a degree of adaptation that occurs with these, as well, as we'll see in just a minute. But basically, by having lots of neurons that can send these signals, they kind of work along with one another. And then depending on how frequently these action potentials are being fired, you can find there's a very wide range of response between very light touch all the way to kind of blistering pain, essentially, and everything in between. The graded response are going to be really good for us. Now, two main types of receptors you're going to find here, especially with touch, are going to be things like phasic receptors. And so this basically means is that when you apply a stimulus, you're going to get a lot of action potentials all up front, and then eventually they kind of slow down a little bit. They kind of have an adaptation period that occurs where they will sense changes certainly, but it's going to be firing off much less frequently than we're at the very initial point here. And so again, some cases like smell, touch, and temperature can all be a big thing here. So for instance, when you have, say for instance, you're sitting in this room, now do you kind of detect really small changes in temperature? Not really. From 72 to 73, probably not a big change. However, if I went from like 72 to 85, you could probably sense that pretty well, right? I imagine most people could. Or if you got to go from inside to outside, you feel that heat almost immediately. Big changes are important for this phasic receptor because that will then kind of re-kick off this whole action potential cascade here. And think about things like with touch, like do you feel the shirt on your shoulders putting pressure on that skin there? No, you forget about it after a while because of that adaptation that occurs. Those neurons are still sending the action potentials, but it's not very frequently, right? You don't get a good sensation of that. Now, this isn't going to be appropriate for all tissues, but for some things where we don't need to have that kind of constant sensory input, it's probably okay, right? Smell's another thing where you get quickly tolerant to certain smells. So for instance, if someone eats or like heats up their fish in the microwave in the break room, hopefully no one does that, but you smell that really nasty fishy smell, and then eventually you kind of forget about it, or essentially you kind of get used to it, and then that sensation is kind of going away because it's kind of there present. However, there's no big changes going on, so again that sensation tends to, the action potentials become less frequent. Kind of make sense? Okay. On the other hand, there's sometimes we want to actually maintain constant kind of awareness or constant feeling of these different sensations. So with these tonic receptors, they're going to maintain the high firing rate as long as the stimulus is being applied. So you kind of see here the action potentials are very consistent from when you apply the actual stimulus to when you withdraw it. Okay, it's going to be consistent. So again, this is good for things like the vestibular apparatus. Why is that important? Yeah, it keeps me balanced, right? So I need to know constantly where my head's at, where am I sensing these different types of movement, because if I, all of a sudden, if I get kind of used to being upside down or something and then I flip around, like I need to know those sorts of things, otherwise I'm going to get dizzy and fall over, right? How about for like pain? Why is that important? Pain's generally a bad sign for your body, right? So again, if I have my hand on a stove, do I want to get used to that sort of pain? No, I constantly want to be reminded of that so I can move my hand off the stove, essentially, right? So that's one thing you can see. Like things like baroreceptors are really important, especially for detecting pressure, like within the blood vessels. Chemoreceptors detecting pH. Your body doesn't want to get used to a pH of 6.9. You need to constantly know that pH is too low to be able to activate some of these kind of compensatory mechanisms, right? So again, these are all things you want to have constant, at least awareness of, or at least your sensory inputs want to have constant awareness of. And that's why those action potentials never really slow down at all until the stimulus is withdrawn. Okay, so those are two main types, the phasic and then the tonic sort of receptors. So these are called slow adapting, and then the phasic would be fast adapting or quick adapting. Okay, and then looking at the different types of accommodation that can actually occur here is going to be very dependent on the types of tissues you're dealing with. So for instance, when you're looking at something like a Pacinian corpuscle, which we're going to see is located within the skin, that can adapt very, very quickly. That's kind of like, feeling of, your clothing on your skin. You forget about that pretty quickly. However, things like the muscle spindle can be very important for maintaining, that proprioception of where my muscles are at roughly in terms of contraction and things like that. The joint capsule receptors, I want these to be pretty slow adapting because I always want to be aware of kind of what that proprioception is so I don't fall over flat on my face, right? All right, so any questions about that so far? Moving into talk. So we're going to find lots of different types of receptors that are here, and they all have kind of specialized roles depending on what we're dealing with. And again, as far as memorization of things with the test and whatnot, having a different idea of what these receptors are doing, have just a general idea. I'm not going to get so very specific that I'm going to be like, okay, which one of these very specifically detects vibration versus indented touch? I'm probably not going to get that specific on it, but some of the big key takeaways here are going to be things like the free nerve endings. These are very important for things like light touch, but more importantly, these very frequently are transmitting pain signals and transmitting signals about cold and heat. So those are good to know sort of things. We're going to have things like the Merkel's disc, which are good for like indented touch. And you kind of see where they're located on the skin within these kind of subdermal layers. And you can kind of make sense of where what type of signals are going to be picking up. Things like Meissner's corpuscles are good for like vibration and touch. Again, some of these are going to be quick adapting, some of these are going to be slow adapting depending on what the sensation you're detecting is. Things like Pacinian corpuscles are good for rapid changes in mechanical states of tissues. I'll show you some examples in a minute here. And then also vibration is good. And then some of these Ruffini endings are good for stretch. So if you're stretching the skin, you want to be kind of detecting that. And again, most of these skin things, most of them are going to be quick adapting, but some may be a little bit slower, especially with like the free nerve endings if they're detecting pain. So again, the Merkel's just a better kind of picture of this. So again, good for indentation. Notice they're kind of right at the surface of the skin, so that way you can kind of detect very shallow indentations pretty easily. Things like Meissner's corpuscle good for texture. If you're kind of running your hand over something, you can detect changes in texture. Pacinian corpuscle good for. And notice these are deeper, so these are going to be able to detect kind of deeper vibrations or more strong signals as you get like a higher indentation into the skin. And then I mentioned the stretch receptors there with the Ruffini endings. Again, the hairs are also going to be detecting some of these signals as well. So again, you can kind of feel when the hairs are going to be being brushed and things like that. We'll also pick up some signals there as well. It will help kind of coalesce into one picture of like what the kind of sensation is on the skin at any given time. Okay, so there's two main pathways you're going to be seeing as far as transmitting these signals from the skin up into the brain. So we're going to talk about these pathways for each of the sensory, or each of the senses we're going to talk about today. So these are kind of good things to have an idea about. Well, how are we transmitting these signals? How are they getting from the target tissue up in actual to the brain? How can they be kind of organized and sent out to different areas of the brain for, one, so we can sense whatever the input actually is, and then we can have a compensatory output to deal with that, right? Whatever it happens to be. So the two main things you're going to see here, there's going to be a dorsal column, what's also known as this medial limniscal pathway for sensation, for touch, and then there's also going to be an anterolateral system. And I'll show you some pictures of what these look like in just a few minutes here. But basically, you're going to find that with this dorsal column pathway, the sensations going through the nerves are going to be traveling along the dorsal columns. We're going to find that, and I'll show you some pictures, again, much more clear when you actually look at those. Another thing to note here is that when you're detecting, say, sensation on the right side of the body, which part of the brain is actually picking that up? Right, again, so it's going to be on the left side. So it's important to also know like kind of where the actual crossover is occurring there. So that's another thing we'll kind of point out on these pictures here. And so you can kind of keep an eye on saying, okay, well, here's the primary nerves, where are they actually interacting and then crossing over and before they actually get to the opposite side of the brain. So that'll be another important thing we'll kind of talk about. But anyway, so eventually all of this is going to be maintained, or eventually synapsing in the thalamus. Right? Thalamus is going to be our main sort of integration center where you kind of take in all these different sensations and can then output them to different parts of the brain. So thalamus is very important. Most of these sensations we're talking about today are going to be inputting into the thalamus at some point. So now this is a very fast sort of transmission of these signals here in this medial limniscal pathway, which is good. And they have these kind of large myelinated fibers. I mentioned when they're myelinated, right, there's big nodes of Ranvier, they can transmit the action potential along. That helps to speed that process up, which is good because the sort of signals they're going to be sending are going to be things like, high degree of like spatial awareness, things that you kind of need to know in a very fast sort of basis. So that way you don't do something like fall on your face or whatever happens to be. The anterolateral pathway, on the other hand, is going to be a little bit slower. We're going to see how they kind of differs in as far as the nerve pathway goes, and I'll show you that in a minute here. But this is going to be good. It's a little bit more broad spectrum in what it's transmitting, a little bit slower, but it's going to be sending things like pain signals, warmth, cold, and kind of more crude tactile sensations, right? So again, maybe not like a small pinprick, but maybe more kind of large sensations you get, kind of more crude sort of tactile sensations. So, again, looking at their purposes here with the medial limniscal pathway, you're going to see that touch requiring high degree of localization is good. And when I say localization, what does that mean? So if I had my eyes closed and you started poking me somewhere on the body, I should be able to localize where that's at, correct? Like if I poke you on the back, you should be able to differentiate that from your front, correct? Most people probably should. However, when you talking about actual degrees of localization, they can get much more fine than that. So we're going to talk about differences in how you can pick up say a pinprick that's only say 1 millimeter apart versus one that's like say 10 millimeters apart. And again, certain tissues are better at picking up those small differences rather than others. So for instance, do you think your fingers or say like your back is better at picking up small differences in that localization? Or your fingers, right? You have a lot more nerve endings there that are meant to transmit those sort of signals, and that's all through that medial limniscal pathway, right? So again, with our hands, we want to have good fine sensation and good localization where those signals are coming from. So again, these typically are going to be phasic sensations. So again, they're going to have strong action potential, frequent action potentials occurring early, and then they're going to have kind of tamp down as that sensation remains constant. And then when it withdraws, then it can kind of reset itself. This is also good for position sensations from the joints, which can help us to remain upright or whatever position we want to be in, and then also pressure sensations. On the anterolateral side, this is again going to be things that are more kind of crude sort of sensations we're seeing there, but also things like pain, thermal sensations, tickles, itch, things like that, and even sexual sensations tend to go along this pathway as well. Okay. So here's a good picture of this. So here's the dorsal column or the medial limniscal pathway. So again, what you can see if you have like say a fine sensation, say for instance you were pricking the finger or say the toe or something like that, you can kind of see where these signals are going to be coming up through. So essentially what you're going to notice is going to be coming through the dorsal horn, right there in the spinal cord. It's going to be coming up, and then this is where it's going to initially synapse here. Okay, so again, we're in the lower medulla oblongata. That's where it's going to synapse. And then what do you notice here about the pathway? Crossing over at this point, right? So again, this is where it's going to be crossing over to the contralateral side, and then it can travel up to the brain. So then it travels up here. It's going to go into the thalamus, where then it can, thalamus up here, and then that is going to go out into the somatosensory cortex. Okay, we'll show you again a little bit more detail what that looks like in a second. But this is going to be that, again, those quick sensations, very fine, precise sort of sense of touch are going to be heading through this pathway here. Does that make sense so far? Okay. Again, you don't have to remember each and every step of this pathway. Just know that, hey, where is it crossing over at, and then kind of where is it going to. Again, everything is going to be ending up in the thalamus at some point, and then transmitting out to whatever kind of terminal area it's going to. In this case, if you go into the somatosensory cortex there on the edge of the brain. So this picture always really creeps me out. Anyone know the name of this guy? Homunculus. I don't know if anyone watched like Attack on Titan, but this guy always reminds me of those big giant guys. There's a few of you might know what I'm talking about. But anyway, so basically this kind of shows us kind of where all these nerves are going to be terminating at after they enter the thalamus and getting sent out here. And what do you kind of notice about this homunculus? Where do you notice and then again the size of the size of the organs here, the size of the parts of the body are going to be kind of proportional to the number of nerve endings that are ending up in that part of the somatosensory cortex. So what do you kind of notice about this? What has like the lion's share of the nerve endings associated with it? The face is a big one, right? So again, you have a lot of good proprioception, a lot of good kind of tactile sensation in the face, which is good. Where else? The extremities, right? So again, the hands are another big one, right? So again, the hands are probably even more so than the feet, which is good because our hands are, that's how we do a lot of things during our day, right? So again, but other places may not have a lot of nerve endings associated with it. And so you can see the more nerves that are associated with this, the better degree of localization we can have, the better fine precision we can have in as far as that sensation of knowing like, okay, where are these signals actually coming from? Somewhere like the back, you're not going to have a whole lot of signals coming from there. So I can detect, kind of crude differences in where something might be affecting the back, but you're not going to have a high degree of localization. I'll show you again in a picture in just a second how we can actually test for that. But what you're going to see here is that here's a somatosensory cortex area 1, and here's area 2. And again, everything kind of has its own little area that it's going to be projecting into. So signals from the fingers are always going to end up in this portion of the somatosensory cortex, and then that can then communicate with the primary motor cortex. And does anyone know what that's going to be used for? We're going to talk about it at the end of this class. Yeah, that's how we're actually going to be initiating movement. So it's good that there's a very close association here because they can send those signals across and say, okay, well, I'm sensing there's pain coming from, or I'm sensing some sort of signal coming from the hand. I should probably move that hand away from that, right? So again, that can be a very fast sort of process there. Okay. So again, areas of larger areas of somatic cortex are going to have a larger number of sensory receptors there. Okay. So looking at this, you can see that even if you have like a single nerve that's actually being stimulated, say this is out in the skin somewhere, you're going to find that it has multiple projections, right? So again, one neuron can communicate with several via its terminals there. And so what you can find is you can actually have this process of recruitment essentially, where you have one nerve being activated that can recruit several other neurons, that they themselves can recruit several other neurons, and then you get a much larger signal than you could by just that one nerve by itself. So for instance, if you have a very weak stimulus, maybe only kind of picking up these nerve endings here in the middle. However, as I start to amplify that signal, I give it a larger signal, more action potential, so I'm going to be able to recruit more and more of these guys. So that way, by the time that signal gets up into the somatosensory cortex, if I have all these nerves that are all firing off at the same time, I know, hey, that's a pretty big signal versus fewer nerves is firing, shows me it's going to be a smaller signal. Okay. Now, the question is, how are you able to differentiate between, say, two different points? Say someone's kind of, you have one of these pinpoint sort of detectors here, where basically you can have different distances between these 2 points, and ideally, the more nerve endings associated with tissue in the somatosensory cortex, the smaller the difference you can be able to detect there, right? The way they can do that, I can actually differentiate between these two, is what we call lateral or surround inhibition. Anyone heard of this term before? What that means? Basically, it's a way that your nerves can kind of shut off kind of surrounding nerves in order to kind of differentiate that signal from one another. So for instance, here I have two adjacent points that are being strongly stimulated. If you were to send these up and you did not have a high degree of lateral inhibition, you're going to notice it's going to feel like just kind of one big signal here, this kind of big blue line. In some areas of the body, you may not be able to tell that difference there, and that's going to be a less fine sort of sensation than you would get in, say, somewhere like the fingers. However, with the fingers, what you're going to find is that these nerves are able to kind of shut off one another in a lateral sort of manner, so that way you can detect two fine individual signals there. And so that way things like the big toe may only be able to detect a 2-point touch, maybe at 10 millimeters. The fingers, though, first finger 2 millimeters, so very close there. However, places like the calf maybe only 48 millimeters, right? So again, there's a lot more lateral inhibition that can occur here in the fingers because you want to be able to detect those small differences in touch. Make sense? So lateral inhibition will also come up again later on with some of the other signals. It helps us to provide contrast though between, so that way we don't just get everything gets kind of blurred up into one big action potential. We want to be able to differentiate those things so that we have some contrast between one another. Okay, this will become big in vision as well later on. Okay, the opposite of the medial lemniscal pathway is going to be this anterolateral pathway. Again, these are better for kind of crude sensations of touch. Is also being good for heat, cold, and then pain as well. So again, you're going to find that if you were to have, say, like a pain signal that occurs here, notice it's going to be synapsing very close to where the actual signal is coming in at. So as soon as it enters the spinal cord, it's going to synapse here and then cross over, and then we're eventually going to end up in the thalamus and then into the somatosensory cortex. So again, this is a slower pathway. It's not going to be as quick as you would see with the lemniscal pathway, but is still good for these kind of more crude sensations here, especially the temperature and the pain sensations. So as far as pain sensation go, or again, the other term for that is nociception. Yep. So we're going to be kind of two major pains that we're kind of dealing with. So there's going to be fast pain. These are usually going to be felt very, very quickly, say within like a tenth of a second after a stimulus is applied. Typically, this is going to be more like acute, kind of sharp, pricking sort of pain. Usually not going to feel really deep into the tissue. So if I were to stab you with a needle, this would be an example of a sort of fast pain, right? Versus a slow pain, usually can be felt, say, like greater than a second. And typically, it's going to kind of more slowly kind of build up over time. It's a little bit more of a gradual sort of pain that you would see than like a fast pain signal. Again, this is going to be more of those kind of aching, throbbing sort of chronic pains. Usually when you hear someone like complaining of like kind of deep like abdominal pain or something like, some kind of sort of visceral organ pain, this is usually kind of what they're referring to as that kind of slow pain that develops there. Okay, most of this pain signals are coming from these free nerve endings. So again, this can either be mechanical signals, they can be thermal, chemical, as we mentioned. I mentioned capsaicin, phenolacin and peppers is a good one. These are usually going to be slow pain signals, and these are usually going to be mediated by things like histamine, serotonin, bradykinin, lots of other kind of inflammatory sort of mediators, which we'll talk about later on. Notice here these receptors adapt very little, and that's good because, again, if we're experiencing pain, we want to know about it so we can get the signal to go fix it, essentially, right? In some cases, it may actually become more sensitive over time. It's actually called that hyperalgesia. When patients, especially like chronic pain patients, they tend to, their pain gets worse over time. That could be these receptors getting more sensitive as time goes on. So again, looking at these two pain pathways, you can see here how they're going to be, again, traveling during using this anterolateral pathway. Again, they're going to be synapsing here early on in the spinal cord as they enter in. We're going to talk about some interneurons that are going to be important for pain relief, which we'll talk about in a second here. But basically, they're going to be traveling up. And you're going to see they have kind of two main pathways. Basically, the fast pain fibers, because you want to be able to detect those very, very quickly, those actually kind of bypass the thalamus a little bit and kind of go directly to the somatosensory cortex, versus the more slow pain sort of fibers are going to be kind of here in the thalamus. It might, again, take a little bit more time to pick up on that pain, but again, tends to more identify with like organ sort of pain or kind of deep tissue sort of pain. So again, that fast pain track is going to be this neospinal thalamic track. Again, usually going to be detecting a high degree of localization to this because, again, it's associated with kind of like more tactile sort of feel to it. And most of the time when they're releasing neurotransmitters, because again, that's how they kind of send their signal along, is normally going to be sending things like glutamate. Glutamate is going to be a primary excitatory neurotransmitter. When you send out glutamate, you're typically going to be signaling or trying to stimulate secondary neurons from there. So again, that's usually how it's going to be transmitting signals. The paleospinal thalamic tract is more for that slow pain. This is where things like substance P is going to be really important here. Anyone heard of substance P before? So again, it's a mediator that actually helps to signal that sort of slow pain. Again, you can also find this out in the peripheral tissues as well, but it's a very important pain mediator. We'll talk about this more in pharm when we actually get into the actual pain relieving medications. Substance P can be a component of that as well. Okay, so how do we deal with pain ourselves? Like, our bodies actually can produce certain chemicals that actually can help with this. They're kind of like natural sort of opioids. So anyone know the names for those? I'll kind of give it away in the slide. It's called enkephalins. Anyone ever heard of enkephalins before? These are the body's own natural sort of pain relievers, essentially. It's kind of like your body produces its own version of heroin or morphine or something like that to try to deal with this pain, right? And so that's good because, again, we don't want to necessarily always have these really strong pain signals. We want to be able to deal with it to some degree. And so you're going to find that the neurotransmitter serotonin is really important to help with this enkephalin release, and then the enkephalins themselves, okay? These are considered opioid-like substances. So when you take something like heroin or morphine or codeine, codeine or fentanyl, any of these drugs, they are going to be working through these same pathways here, these same sort of receptors. And so some of these include things like beta endorphin, metenkephalin, leuenkephalin, dynorphin. It's not important to remember specifically where these are working at. Just know that the body is producing its own enkephalins, its own way of causing some analgesia. You can kind of see how these are working a little bit. So for instance, one of the ways that opioids were described to me originally is that like it doesn't really, eliminate your pain, but it's more like it kind of makes it so you don't really care that it's there, right? You have less of a sensation of it. And so that kind of makes sense because if you imagine there's a pain signal happening, say you stepped on a nail or something, and that signal is coming into the spinal cord, there's going to be these little interneurons here that are actually sending out some of these enkephalins, and by releasing that, it's actually going to cause an inhibitory sort of effect, so that you have a lesser signal traveling up and into the brain, right? So less of that signal of that pain actually made it through all the way up into the CNS. This can happen again later on, up in the further up in the CNS. You can have some of these nerves here. They're going to be producing enkephalins that can actually help to inhibit that signal as well. Okay, so again, it doesn't necessarily get rid of the pain, doesn't deal with the pain that's actually happening at the tissue, but what it can do is try to limit that signal that's reaching up into the CNS. Yes, ma'am.
Have something to do with like pain tolerance, or is it like women can deal with pain a little bit better than men can?
It's a good question. Is that just a myth, or is that true? You think so? Interesting. There's a funny. Okay, that reminds me of a funny joke. Just a brief aside. Anyone mind if I tell a quick joke? Okay, there's a married couple, and they're at the hospital, and the wife is about to go into labor, and the wife is really concerned about the pain she's going to experience there, and so the doctor comes in and says, well, there's this new device that actually transfers some of that pain from the mom over to the dad. And the mom's like, absolutely, let's do it. So they hook it up on the mom, and they're going through, and she's going into labor, and she's like, oh, it's starting to get a little painful. And it's like, let's try transferring 10%. Transfer 10%. The dad's like, nothing, I don't feel anything. It's great. Childbirth's no big deal. So I said, let's turn it up. Let's go to 50%. Dad's like, no, nothing. This is awesome. Mom's a lot less pain. She feels comfortable. They're like, let's crank it all the way to 100%. 100%. Dad's like, this is great. This is awesome. Nothing's happening. Anyway, they have the baby. 2 days later, they go home. They find the milkman dead on the doorstep. So to answer your question, could there be some gender differences here? Possibly. It's out of my purview. I'm not really sure. But yeah, it could have something to do with that. Maybe the amount of enkephalins are producing, or the way some of these pathways are being transmitted. Who knows? So yeah, it's a good question. What was that? What was that? Oh, well. I'm just glad that device wasn't around when I had my kids. So. But fortunately, we have epidurals, and those things work great. I'll never forget. So one of the side effects you can see with epidurals, usually they're instilling something called a local anesthetic, something called lidocaine, and usually an opioid like fentanyl. And so they're instilling that right into the epidural space there. And so basically, it provides a very good kind of positional sort of anesthesia. So that way, basically from the waist down, you're completely numb. And then from waist up, you should be good to go, right? So you don't really have any changes in sensation there. And so one of the side effects is hypotension, though. So you can see that. So your blood pressure can drop with those medications there. And so my wife, her blood pressure tends to run a little bit low on normal. And so I started seeing the blood pressure kind of drop a little bit. And I was like, I don't know, maybe they should turn this down a little bit. And she's like, if you tell them to touch that thing, I will kill you. I will reach over there. I said, well, fortunately, you can't really move your legs right this moment. So anyway, she did fine at the end of it. Anywho. Right, so again, the main thing here is the enkephalins are very good at suppressing that pain signal. Again, sometimes we have to give patients additional opioids in order to help kind of get over that hump, but everyone can produce these on their own, essentially, to try to limit those signals hitting up into the CNS. Okay, has anyone ever heard of referred pain? What is that? Pain travels. Yeah, so pain is originating from one area, but is being felt somewhere else. And so, for instance, probably the most kind of well-known one is going to be when you're having a heart attack. Where do you normally feel pain? Yeah, in the left arm, right? So again, you're having some of that referred pain that you're having, especially up into the jaw, left arm. You feel that pain, and so that's considered to be a referred pain. A lot of abdominal pain is kind of hard to diagnose in a lot of cases because a lot of it's being referred out to other parts of the abdomen. So it's hard to tell, okay, was this the appendix causing a problem, or is it the colon and the gallbladder, And the reason for that is because actually a lot of the visceral nerve fibers, and again, visceral meaning we're innervating the organs, kind of get mixed up with the signals from the skin nerve fibers. And so because there's some of that overlap there, your body is detecting pain, say in the left arm, even though that's not really what's in pain at that point, right? This is the fact that you're having a little bit of bleed over of those signals coming from the heart detecting that ischemia, traveling over, and then you're getting that referred pain there. So again, that's just one thing you may hear, where basically a remote tissue is in pain, even though that's not really where the pain's actually at. It's usually going to be in more of a visceral sort of organ. Okay. Now, thermal sensation, again, this gets regulated through the same sort of pain fibers, usually going to be those kind of free nerve endings. And typically, your body's going to have a lot more cold receptors than it is going to have warm receptors. Whatever reason, you want to basically, if you're like looking at, and again, depending on the tissue you're dealing with, you can find different numbers of cold receptors and warm receptors. Basically, like on the lips, you tend to have a very high concentration of these, whereas like on the trunk, you maybe have less than 1 per square centimeter, right? So again, certain areas of the body are going to feel that cold more quickly. Now, there will be some adaptation to that. So again, if you move into like say a new environment, you go from inside where it's nice and cool to outside, you're going to feel hot initially, but again, you're going to initially kind of that signal is going to go down to some degree. It's a little bit of that phasic response there. And so it's good. However, anyone ever watched that movie, Dante's Peak, back in the day? About the volcano that went up? Okay, one person, great. Anyone heard of like trying to boil a frog? Heard that analogy? Basically, if you want to boil a frog, if you put him into a big pot of boiling water, he's going to hop right out. He's going to detect all that heat there because there was a big change in the temperature that skin detected. However, if you were to, say, put it into room temperature water and then slowly increase it over a period of time, he never senses it to a great degree, and then you have a boiled frog. Why you want a boiled frog, I don't know. I don't know where that analogy comes from. However, it's probably somewhere like where I grew up. We had a lot of frog legs and stuff we ate. But anyway, that kind of goes to show you that your body can detect large changes in temperature, which is good. Anyone ever like went from like a hot tub and like jumped into a cold pool? It feels much colder than if you're at room temperature and jumped into the pool, right? So again, we detect big changes in temperature, but small incremental changes over time are harder for us to detect, right? That's kind of one of the big things you're going to notice with temperature changes here. Okay, so it's kind of general sort of touch sort of sensation. Any questions on that so far? Yes, ma'am.
Can you have increased pain receptors in places? Because I had a torn labrum, and when it dislocated, it was okay, but if I bumped into something, it would be like terrible.
It depends. Sometimes it could be related back to inflammation. What you find is, early on in like an injury, before there's been like a chance for the body to have a good like kind of inflammatory sort of response, so you may not notice a whole lot of pain with it. Also, additionally, like your body can withstand a lot of pain like in the acute phase because a lot of those endorphins and stuff you're releasing. Some cases when you have the inflammatory response occur, this is where you're going to have like more like white blood cells that are kind of infiltrating. You're having a lot of like prostaglandins being synthesized and things like histamine and all of that. Those tend to sensitize those nerve fibers. Like substance P is a big player there too as well, which is why with some injuries they may not feel that bad initially, but then in the subsequent days they feel they're much more painful due to that inflammatory response. Some of that has to do with just the sensitivity of those nerves being made more sensitive, that hyperalgesia that occurs over the course of a few days. That kind of answers your question. Any other questions? Okay, moving into talking about our cranial nerves. Have you guys covered any of this in anatomy yet? Okay, familiar with the cranial nerves. You can recite them all 1 through 12 for me, right? Probably. Anyway, we'll talk about these as they become relevant to the different sensations here. So again, we'll see these come up again. Just you can refer back to this if you need to, but we'll talk about them in their specific uses. Again, most of them are going to have some sort of sensory impulse or sensory sense that is going to be picking up some sort of signal that's going to be transmitting to the brain. A lot of these can also have some degree of somatic movement control as well. And I say somatic movement, what does that mean? Gotta like move something, right? So again, for instance, when I'm dealing with like say, for instance, like the abductans, like cranial nerve 6, when I'm trying to move the eye in a particular direction, that's going to be more of a somatic sort of motor impulse rather than just something like proprioception or a sense of smell or something like that. Or olfaction would be a sense of smell. So again, you can refer back to this. Again, this is going to be something you're going to be testing in a lot of your patients. A lot of times in your notes you're going to say cranial nerves 2 through 12 intact, and you're testing for all of these things essentially when you're working with your patients. So. The vagus nerve is particularly important, at least to my purposes as a pharmacist, because we have so many drugs that can affect the vagus nerve. Anyone know which type of nervous system is related to the vagus nerve? Yeah, parasympathetic nervous system is very important with the vagus nerve. This is the main thing that's going to be transmitting those parasympathetic signals. So that becomes very important for my purposes as far as medications go, because we have a lot of drugs that can either enhance this or inhibit it, and it comes up all the time. So again, the vagus nerve we'll talk about later on. We talk about the autonomic nervous system, but very important from that standpoint. Okay, so let's see what time it is. I got 10 minutes. Let's start up with the eye. So the eyes have it, right? Maybe. Have you guys covered the eye at all yet? All right, fantastic. You guys are probably more well versed with it than I am. Perfect. We'll talk about the function of the eye, though. That's what I like to cover here. Yeah, the different portions here. Again, I'm not going to talk about each and every single one of these pieces of anatomy. However, as they come up and relevant, as far as vision goes and as far as movement of the eyes goes, this is where I'm going to be kind of focusing on from this standpoint. Okay, so kind of notice there's kind of major components to the eye here. There's kind of major chambers essentially. So we're going to have the vitreous chamber, which is also known as the posterior cavity. We're also going to have the anterior cavity here, and this gets broken down into what? Yep, posterior and anterior chamber. Those are important to know because, again, if you have pressure buildup here, anyone should call that ocular hypertension. Yeah, glaucoma becomes a big deal, especially in a lot of older patients. We'll talk about why that is a little bit later, but again, this is a big deal as far as like the pressure buildup there. Again, those are the kind of the two main delineations there as far as like different compartments of the eye. So looking at the internal anatomy, notice here that usually the direction of light is going to be coming through the pupil first, going through the lens, and it's going to be hitting to the focal point usually. And again, this is kind of normal sort of vision here. So we're going to see how that all works. We're going to look at the rods and cones. We're going to look at the lens and how we can change that. What do you call it when you're changing the size and shape of the lens to help with the vision? Accommodation. Yeah, we're going to talk about accommodation, pupillary constriction, all the good stuff. We're going to get into details on that coming up here. Okay, so looking at the eye here, so again, if you're looking, say, through an ophthalmoscope, you're looking at the left eye, you're going to notice here you have your optic nerve coming in through here. We call this the optic cup. Anyone know what else is coming through here? Yeah, a lot of blood vessels and whatnot, right? So again, a lot of the blood supplying oxygen and whatnot to the eye, and a lot of the veins are going to be coming here through the optic cup. What's kind of notable about this one in regards to vision? Yeah, that's your blind spot essentially, right? So again, we can't really have any rods and cones that are stuck here because we have to have material going back through the eye. So again, that can be kind of your blind spot if you hear that when driving or something. We're gonna have the fovea surrounded by the macula here. This is gonna be really important because what does this do for us? Yeah, so this is going to be where we're going to get basically where we're going to try to focus our image on our eye, on the retina, in order to get the best picture, right? And we're going to see there's a lot of rods here, some cones as well. But this is going to be the greatest concentration right there. So again, this is where we're going to try to focus our image when we're looking at something. Okay, certainly you're going to have your arteries and veins and whatnot, and then it's going to be, and usually in the case of the retina, there's going to be kind of a passive sort of diffusion here. So again, when you have the eye, which is again using quite a bit of oxygen to make ATP and whatnot, is going to have a higher concentration of CO2 that can then passively be absorbed through the veins. The arteries coming in with nice oxygen-rich blood can then diffuse the oxygen in there. So it's kind of a passive diffusion, especially here with this vitreous humor that's going on here. And again, we can only see a very small portion of the electromagnetic spectrum here. So again, this is kind of visible light. Below those, depending on the wavelength and whatnot, is where we can get into things like ultraviolet rays, infrared, all that good stuff. But this is basically kind of what we're looking. Our visual field happens to be in this realm of visible light. Okay, so again, as looking at the visual pathway, as light passes through the cornea, it's going to go into the anterior chamber and then to the anterior cavity of the eye. Okay, so again, it's anterior chamber of the anterior cavity there, and it's going to pass through the pupil. And what's the pupil kind of helping us to do? Yeah, it's letting light into the eye, and so we can change the size of that by changing what? By causing changes with the iris, right? We can form either a smaller opening or a larger opening. What do you call that? What do you call it when you have like a really wide open pupil? Dilated. What's the other name for it? Mydriasis, good. Or if there's like a say very kind of low light situation, high light situation, you can constrict that back down and make a very small sort of pupil. What do you call that? Meiosis, yeah. So those are important things that will come up. There's actually a lot of drugs that affect that. So we can, when I'm evaluating a patient, especially for like a tox sort of thing, I can look at their pupils and get a lot of information out of that because certain drugs can affect that. So for instance, if you were to like abuse something like amphetamines or cocaine or something, they come in, they have these big saucer-looking pupils because they have all this kind of sympathetic outflow on there. We'll go into details on that versus someone who like say abuses an opioid like fentanyl, they tend to get really small myotic sort of pupils. That's one big thing you're going to note there. As it passes through into the posterior cavity, it's going to go through the lens. And the lens is really important because we can change that accommodation there, what the actual focal point of the light that's entering the eye is going to be. And that's how we can kind of focus our vision, essentially. And then once it hits the retina, that's where we're going to have our photoreceptors. The photoreceptors are primarily what? It's like our rods and cones and things like that. That's what's going to be picking up the signals from that light. And then that can be transmitted through the optic nerve and into the brain. Okay, so we're going to kind of go into more detail on how all that's occurring here just a little bit. Why do you think the back of the eye is so black? We have that pigmented epithelium. Why do you think it's so dark back there? Well, because usually darker colors absorb or reflect light. usually absorb light, and that's good because when you have light coming into the eye, you don't want it to reflect off of something and bounce everywhere, because then you really wouldn't have a good perception of that vision, or you wouldn't have whatever you're trying to focus on. You wouldn't really have a good picture of that. You have that really darkly pigmented epithelium, because that way the light is going to be in there, is going to be absorbed by that, and then you're not going to have a lot of refraction of that light elsewhere, which is a reason why that's more black. And then who might not have the ability to have that kind of darkly pigmented epithelium? Yeah, albino patients, because again they are lacking that melanin, so they actually have issues with their vision because they don't have that same darkly colored sort of epithelium there. Looking at the visual pathway, you can again see your object here. Notice that the image is typically going to be flipped, right, when you see that. But the brain, fortunately, is smart enough to go ahead and pick it up and flip it back around again for us. That's how we can see things right side up when we are. You'll also notice here that as the light passes through different mediums, it's going to change how that light's being refracted, essentially, right? And so that's going to be affecting how the light is going to be focused on the back of the retina, right? Typically, the fovea is where we're going to have our center of our vision, essentially. And so the main thing it's going to be able to change to accommodate for that is going to be the lens, which helps us with accommodation, right? So we're going to look how that's going to work a little bit later on. And so when you're looking at how well the lens can refract that light, this is where you can see how we can change the shape of that and change where the focal point's actually going to be. But anyway, some things to note here. So again, we have the cornea is going to be, the light's going to travel through here. The lens, notice here we're going to have these suspensory ligaments. These are important because this is what's actually holding the lens in place, and we, by changing how the muscle around those ligaments are being constricted or relaxed, that can actually affect how the shape of the lens is going to be conforming there. So what else? And we're also going to have, again, if you're looking at the ciliary muscle here, this is going to be the big thing that's affecting those suspensory ligaments there around the actual lens itself. Okay. So again, going through the anterior cavity to the posterior cavity, you can see here how the fovea is where the primary place where a lot of that light's going to be focused on. Now, if I can't focus, the lens is maybe unable to accommodate for that light, and I'm not able to focus correctly. This is where we're going to end up with things like nearsightedness and farsightedness. We'll talk about that, hyperopia, myopia. We'll talk about those a little bit later on. And a lot of that has to do with like the shape of the eyeball. If it's too long or too short, you can run into issues with being able to really focus that light as you're supposed to on the fovea there. And then finally, towards the back of the eye is where we're going to be getting into that pigmented epithelium. You can see right here, again, it should be pretty darkly colored. You're going to be seeing your rods and cones, and then there's going to be a series of nerves that's going to be traveling to and sending signals to, and we'll get into more detail on that happens in a few minutes here. But eventually it's going to hit these ganglion cells, and this is what's going to be working with the optic nerve. So it's going to be sending that signal to the optic nerve up into the brain. Notice here, this is actually towards the front of the eye, so when light's coming, it's coming in this direction, and it kind of hits the back of the wall here. And again, this should be dark, so that way that light doesn't just end up refracting off of that and hitting more rods and cones than it should. Does that kind of make sense? Okay. So looking at the pupil and the iris, not that iris, but this iris here, you can see that by changing the diameter, which is controlled by cranial nerve 3, the oculomotor nerve, we're going to see this come up again as far as like eye movement as well. So it's kind of pulling multiple jobs here. We're going to find that when you have constriction, this is actually going to be contracting these circular muscles right here, right? So again, by contracting these muscles here, this is what's going to cause that miosis, that pupillary constriction. This is mainly going to be maintained or being affected by the parasympathetic nervous system. We said parasympathetic is what kind of nervous system? Rest and digest, right? So again, if we're kind of resting, we're just kind of sitting around after you had like a big lunch, and you don't really need to see a whole lot. So those pupils can constrict, and that's okay. On the flip side of that, if you were to have contraction of these radial muscles here, it's kind of pulling the iris apart and kind of pulling it to the edges there. And so this is when you end up with that dilation. This is when you end up with that mydriasis. And notice here which nervous system is affecting it. Sympathetic, right? Which is also our fight or flight. Good. So if you're in a fight or flight sort of scenario, you want to have as much light coming into your eyes as possible so you can see as much as you can, so you can run away from whatever that thing causing the response is, right? So again, it's usually mediated by things like norepinephrine. Epinephrine is going to be causing that constriction or that dilation to occur. Whereas what is the main neurotransmitter for the parasympathetic nervous system? Yeah, acetylcholine, when we talk about that, we'll get into more detail on that, but acetylcholine is a big thing that's going to be affecting that, and that's usually through those muscarinic sort of receptors. I can see those pupils start to constrict there. Okay, so just know that for the constriction there, you're having contraction of those circular muscles. For dilation of the pupil is where we're going to be seeing contraction of these radial muscles. Okay, so again, they're kind of pulling things apart in that case. So in a dim light sort of scenario, you're trying to let in more light, so you're going to have more of that sympathetic nerve being activated. It's going to try to constrict those radial muscles. If you're in a low light sort of situations where you have the circular muscles, bright light situation, you're going to have the circular muscles start to contract to allow less light to come inside, where we're not going to blowing out our vision, and we're not going to be, kind of out of focus sort of vision there, right? Again, this is going to be through the parasympathetic nervous system there. And so when I have patients who have maybe abused a drug that activates the parasympathetic nervous system, you'd expect their pupils to look like what? Very myotic. You expect them to be very small. And we actually see that if someone were to accidentally be exposed to like a certain type of pesticide, we end up seeing that they have a lot of acetylcholine around that overactivates those circular muscles, and coming in, they have very myotic pupils, and that could be one of those signs that try to tell us what substance it might have been exposed to. So just one example of that. How we can use that clinically, essentially. Whereas they just snort a bunch of cocaine, you're probably going to see that sympathetic nerve being much more active, and that's when they have contraction of those radial muscles, and that's what's going to be causing that mydriasis to happen there. Okay. Anyone ever seen the movie Requiem for a Dream? Did I mention that before? Right, so whenever they do drugs and all of a sudden you see their eyes like kind of constrict or dilate, that's kind of what they're trying to simulate there. Is like, because again, the eyes are usually one of the first things that you can see those big changes to in response to the changes in the sympathetic or parasympathetic nervous system. But anyway, so again, cranial nerve 3 is going to be helping with that pupillary reflex there. Again, it should be constriction in bright light. It's going to be through the parasympathetic, dilation in dim light, or the sympathetic. Know this for this test, these points here. It'll come up again later on. We're talking about more about specifically the autonomic nervous system, but these are good points to kind of take away at this point right here. All right, any questions from the first half? All right, so continuing on, we talked about looking at the iris and being able to constrict or dilate that. That's allowing how much light is going to be hitting the lens, which then flows into the back of the rest of the eye, essentially. So the lens, it is avascular, which is probably good because we want that to be pretty clear for the most part. The question is, like, how does it get its nutrients? How does it get oxygen flow and things like that? And that's where, and again, this is not very funny, but that's where the aqueous humor is going to be coming into play here. Okay. Yeah, boo. Thank you. Now, big things to note with this is it's going to be attached to the ciliary body, essentially, and then you're going to have these muscles are going to be located here that help us to either relax or tighten up that lens to change where our kind of focal point is going to be in relation to whatever we're looking at, essentially. So the ciliary body is good here. It's also going to be producing that aqueous humor, and then you'll have these ligaments here. These zonules are going to be attached directly to the lens. So you can kind of see you're going to have these ciliary muscles that are located around the lens itself. And so if you imagine if you were to constrict these ciliary muscles, what do you think it would do to these ligaments here? They're tighten or loosen? Really? Because if I constrict that ciliary muscle, constrict it down, it should loosen up those ligaments, right? That's an important point to get there. So when I constrict the ciliary muscle, that's going to loosen up those ligaments. And what do you think is going to happen to the shape of that lens? Is it going to flatten out, or is it going to become more kind of circular shaped? It's going to become more circular, right? But however, if I relax the ciliary muscle, that's going to tighten up the tension of those ligaments, and it's going to pull that lens to be much more flat. And we're going to see how that can affect our accommodation and how we're going to be focusing the picture on that fovea, right? Because again, that's where we're going to get the kind of the best picture, essentially, for our eye. All right, so normally you're going to have the ciliary body also making that aqueous humor, which is good. That's going to be one of the big components here that will dictate glaucoma. A lot of the pressure that's building up here in the anterior sort of cavity here. So normally it'll be produced, aqueous humor is produced here in the ciliary body. This is going to flow over the lens, over the pupil, and then to grandmother's house it goes. Not really. Actually goes into the canal of Schlemm, which is one of my favorite organs of the body. So it goes in that canal, and they can then drain into the rest of the venous circulation, right? So again, this is avascular, but we need to have that flow of aqueous humor there to actually provide oxygen and get nutrients and things like that to the lens itself, because those still are living cells there. Now, what would happen if I were to say prevent the outflow of that aqueous humor? Pressure goes up, and that's when you have glaucoma. Or in some cases, it could be we're actually producing too much of the aqueous humor. So when we get to glaucoma, this will be one of the first things we'll talk about in pharm. You'll actually see that we can tackle that by either decreasing the amount of aqueous humor we're producing, or by giving drugs that can actually affect how well that aqueous humor is actually outflowing from the eye. So again, there's you can start to see little ways where we can interact with the body to try to change those normal processes, especially if they're causing disease, and try to get things back down to normal for these patients. Anyway, so again, that's the typical flow here. Again, it's going to be traveling out into the anterior cavity here, and then going into, or the anterior chamber here, and then going into that canal of Schlemm to be then going back to the venous flow. Just another kind of picture showing the same thing here. All right. And again, normally for the posterior chamber, you're going to notice here that you're basically having kind of passive flow of oxygen and nutrients and also waste products back between the venous and the arterial side for these vessels that are coming into the eye through that optic disc, or optic cup, I should say. However, with the aqueous humor here, this was kind of providing a lot of the nutrients here in the anterior chamber. Okay. All right. So light refraction. What is light refraction? Kind of changing how the light's being focused, essentially. And so again, when light is passing from one medium to another, you're going to find, especially with things of different density, you're going to find that it bends, essentially, right? So again, when the light is coming through and passes through the cornea and then passes through the lens, you're going to see that there's going to be little changes to it because it's going through different densities. You're going to find that it's going to bend a little differently. And the important thing here is that the lens is going to be the main thing that helps us to focus that image by changing, because that's the one thing that can actually change. Your cornea itself doesn't really change shape at all, but the lens can change pretty significant. So looking at light coming through, you're going to notice as it goes through the cornea, it's going to go through the pupil here. As it hits the lens, then it's going to be able to bend and then have its focus here right there on the fovea, right? Because again, that's where we're going to get the best picture, and that's where we want our pictures, whatever we're looking at, to be able to focus right there on that fovea, because that's where most of our rods, and there's going to be some cones there as well. That's the highest concentration there. So looking at things, images are typically flipped around, upside down, and then left to right, typically when they're being focused on the back of the retina. But again, our brain's able to take those images and make them right side up for the most part. So that's an important feature there. And then looking at lens accommodation, so typically what you're going to see, we kind of talked about this already, but in order to keep things focused, and again, things as we constantly shift our fixation, what we're looking at, or as that object moves, we need to be able to accommodate that lens pretty quickly in order to deal with that. So for instance, we're dealing with contraction of the ciliary muscles. Again, that's going around and attached to those ligaments that is attached to the lens. As you contract that, that's actually going to be allowing those ligaments to relax. It's going to loosen up the tension there, and that's going to make the lens thicken and kind of get more circular in shape, right? And that's going to be better for kind of more close or near vision, because that's going to be able to take that focal point and kind of move it forward a little bit onto the back of that fovea, right in the back of the retina, where we're going to get the best picture there. On the flip side of that, if we're going to have relaxation of the ciliary muscle, that's when we're going to want to focus on something that's far away. By relaxing on that, it's going to increase the tension on those ligaments, and it's going to cause the lens to thin and flatten, and it's better for more distant or far vision. Okay, and I'll show you some pictures here when we're talking about like farsightedness versus nearsightedness, and how that's going to be, how the lens is really playing a big role in there, making sure we're focusing on things appropriately. So, and then anyone ever seen the Snellen chart? I'm sure most people have used this at some point, right? So what does this tell us? Visual acuity, essentially, right? So it's telling us how well are we able to distinguish what these letters are at various distances, essentially. And so again, looking at this near point of vision, it's basically that minimum distance that the eyes can basically bring an object into view, essentially. And that sharpness, that resolving power, is going to be tested here as well, because you need to be able, because again, if you're looking at the smaller and smaller letters, they tend to blur together a lot. You kind of lose the ability to really kind of distinguish between those two. And so typically when you're checking for visual acuity, you're standing basically 20 feet away from this chart. And so this is basically saying, okay, you're 20 feet away. What's the kind of the last line you're able to resolve pretty well, that you're actually able to read and get correct? And so ideally, when you have 20/20 vision, this is the last line that you should be able to read pretty well, right? Unless you have corrective lenses or something that can help to change that. But again, if you could only read this one, well, this is what you should be able to read at 25 feet. But you're only standing at 20 feet. So basically this top number is going to be the distance you are away from the chart, and then the bottom number is like what you should be able to, what basically someone with normal vision, normal 20/20 vision, should be able to read at that distance, essentially. So if I can only read the E, which I'd have pretty poor vision, I should be able to spot that at 200 feet, essentially. But if I can only spot it at 20, then I would have 20/200 vision, essentially. Make sense? Okay. No nods, but I'm assuming you're nodding in your head. Okay. That's a Snellen chart. And again, here's a good picture kind of showing you the lens and how it can change based on what we need to accommodate on. And so again, that ciliary muscle, as it's going to relax, you're going to find these ligaments become more taut. That lengthens out the lens, is going to make it more flat. It's good for viewing things that are far away. Whereas things that are going to be closer up, we want to have constriction of the ciliary muscles. That's going to loosen up those ligaments and allow the lens to become a much more kind of globular, sort of circular shape there. And again, it's better for near vision. So the question is, well, what about if we have like farsightedness and nearsightedness? What's actually going on with those processes there? And so what you're looking at is that myopia, nearsightedness, which basically means what? I'm nearsightedness, so I can see things up close. Things far away tend to be more blurry, right? So again, nearsightedness typically is going to be a problem where you can't actually focus. That focal point of that light is not able to really make it far enough back to hit the fovea there, right? So again, the focal point is actually in front of the retina there, and so those things, and at that point, the light's going to end up scattering in either direction, and you're not going to get a really clear sort of picture there, okay? And normally, if we wanted to bring this focal point back, we would actually have to tighten up that lens and make it more flat in order for that to occur, but since we can't do that, and usually this is caused by the length of the eyeball being too long, so if you have a long eyeball, you tend to have myopia or nearsightedness. And so basically you can see this dotted blue lines, and they say the normal size eye. So how can we fix that? Well, we can try to give corrective lenses that are going to be able to refract that light out somewhat, so that way we can bring that focal point back to the fovea there. And so this is where you can use something like a concave lens, right? So I have concave lenses on my eyeglasses. That's going to bring that focal point back, and now I can see things that are far away, and hopefully still be able to see things that are close up. Make sense? So again, nearsightedness, you usually have too long of an eyeball, and you're going to need concave lenses in order to focus that focal point back on the fovea there. Next, we have hyperopia or farsightedness. So this would mean near things are. That would be blurry in this case. So usually this is going to be when you have too short of an eyeball. You can kind of see here where the length of the normal eye would normally be. This one's a little bit too short. So this means that you have the focal point for things that are going to be up close tend to be further back than the retina, tend to be focusing behind the retina essentially. And so the way we can actually fix this is if we're going to go ahead and give a convex lens. This can actually bring that focal point up. It can bring it up closer to the retina, and so that way I can now focus on things that are going to be close up for me. Okay. So again, here the problem is the eyeball is typically too short, and we need something that usually concave lens, convex lens is going to be able to bring that light, that focal point back up onto the retina itself. Okay. Yes, ma'am.
When people get that, like as they get older, is it just because their eyeball is shrinking?
Their eyeball is shrinking. That is not the case. I will show you what that is in just a second there. Anyone know what that's called? Presbyopia. We'll see what that looks like in just a second. It's actually not their eyeball shortening. However, as those patients get older, they do shorten. So their eyeballs stay the same length, I imagine. But we will see what happens. It's a very good question. It's probably something I would never have thought of. Like, are their eyeballs getting shorter? I have no idea. Anywho. So you can have some kind of multiple issues that are going on here. So with something called astigmatism. This is basically where you have kind of an asymmetry of either the lens curvature or of the actual cornea itself. And so basically you're getting these focal points that are kind of scattered. You're going to have multiple focal points that are hitting multiple parts of the retina there. And so in some cases you can find you can have blur along sort of more horizontal lines, or you can have issues with vertical lines depending on how the lens is going to be asymmetric. And again, not everyone's going to be exactly the same. So this is usually where you have to get sort of specialized lenses to correct this astigmatism. We're going to use like cylindrical lenses can actually help with this. So again, they would be able to curve it in different ways to get the focal point just right on the back of the fovea there. So here's a good picture kind of showing you the difference, different eyesight sort of abnormalities here. So again, if you had emmetropia or normal vision, again, everything should be focusing right there in the back of the retina. Everything should be correct there. Again, this would be a normal length sort of eyeball here, right? If we had hyperopia, we have farsightedness, we can see things far away, but not things up close, and that's usually because we have a short eyeball, that focal point is going to be behind the retina, and so we're going to need something like a convex lens in order to bring that up close and bring that onto the back of the retina. If we have myopia, we have nearsightedness, we can see things up close but not far away. Usually this is an elongated eye, and this is where we need something that's going to be concave in order to go ahead and send that light further back and focus it back on the retina there. Okay, and then astigmatism is where everything's kind of going all kind of crazy a little bit, and you have multiple focal points, and by getting something that's going to be kind of an uneven sort of lens, like a cylindrical lens, this is going to be able to help correct that. Okay. So to your point, presbyopia, or that loss of accommodation with age, is going to be more related to things like reduced flexibility of things like the lens, right? So if the lens is not able to change its shape as easily as it could when they were younger, that can also affect how well they're able to focus things that are either close up or far away. You can also see things like forward movement of these the zonular fibers. So again, those actual ligaments can actually change position there. And then the lens may not be able to thicken as much. So typically they have problems seeing things that are up close initially. That's where you need things like reading glasses to be able to focus on those things that are up close.
So if you're nearsighted and then as you age and get this, would you also need like reading glasses, or how would you accommodate?
It might be something where you might need to change the prescription of the lens, I would imagine, or potentially if you have like those bifocal lenses, right? So again, they have like a part on the bottom that's going to be better for seeing things up close, essentially. However, you talk to an optometrist, they might be able to give you a much better answer than that. But yeah, I'd imagine it could be either one could happen for depending on the patient, how they're aging, and how things are changing. Yep. Okay. There's also what we call cataracts. These typically are going to be usually caused by UV damage over time, but you have these kind of changes in some of the crystalline proteins, especially around the cornea there. It typically happens more with age, certain metabolic conditions. You can see this heredity. Some people are more likely to get it based on their genetic lineage. Trauma can do this as well, and sometimes they have to have surgery come in and remove those in order to allow for light to cross effectively to get back to the retina. All right, so again, going back to now that the eye has, or the light has crossed the lens, where's it kind of going from there, and what are we going to do to get that vision, that image transmitted back to the brain? So this is the next step we're going to be focusing on here. And again, most of the images should be focused where? On the fovea, right. So again, this is going to be our largest proponent of rods, and then also some cones are going to be kind of located here. This is the biggest thing we're going to try to focus on here. There's going to be still rods and cones kind of lateral to this. However, this is going to be the highest concentration. That's where our focus is really going to want to be. And our blind spot would be where? Moving the optic disc there, right? Because again, this is where we're going to have the optic nerve coming through, arteries, veins, all that good stuff. So this is where you would have a bit of a blind spot. Okay, so the direction of light's coming through, basically you're going to have this pigmented epithelium. It's going to hit these photoreceptors here. And you notice this is, again, light's coming in this direction, so this is where the light is going to ultimately kind of terminate here. We're also going to see, I'm sorry, this is the pigmented epithelium back here. Photoreceptors, then we're going to have some things like bipolar cells. Again, they're not bipolar in mood, but bipolar in direction they're going to be firing. Also going to have some what we call amacrine cells, ganglion cells, and then the ganglion cells are ultimately what's going to end up interfacing with the optic nerve. So it seems kind of backwards. It seems like you'd want to hit your rods and cones first, but actually light's going to be traveling through here and eventually hitting the rods and cones almost last before it hits that pigmented epithelium. That's kind of last thing. And then I'll show you a picture of what this looks like, because actually this conformation changes a little bit, especially in the fovea, where actually you move a lot of this stuff out of the way in order to get the most light possible without being interrupted hitting those rods there. So I'll show you a picture of that in just a few minutes. And again, this is an optic nerve, number 2 here. Okay, so again, looking at the direction of light, again, you're hitting all these optic nerves here. The rods and cones, this is what's actually detecting the light. This is what's actually changing. The signals are going to be sent to the ganglion cells that end up heading into the ocular nerve, right? So again, this is the big thing to note here, is that these are what's going to be generating the signal. It's going to be affecting these cells that end up interfacing with these optic nerve cells, okay? So what is actually happening in we have rods and cones. Cones are good for what? Color vision, right? And then our rods are typically good for what? More like black and white sort of vision, more monochromatic vision is another name for that. And actually, if you're looking at the spectrum of things, so again, we have several different types of cones. We have things like blue cones, green cones, red cones. The rods actually have a close spectrum that they share with the green cones, in which case you never see, like, in movies and stuff when they have like night vision, like what is the color normally? Normally green, because the rods can actually pick up green color a little bit easier than it can any other color, and so that's why when you have like night vision and things like that, that's why it's trying to pick up as much green color as it can in order for the rods to be able to kind of see that essentially, right? One of the big things to note here is that it requires rhodopsin. Rhodopsin is the pigment that's going to be located within the rods. If you don't have rhodopsin, you can't really see much, right? And so what you're going to find is that you really are dependent on having vitamin A. Okay, and vitamin A is, again, one of our fat-soluble vitamins. You remember the other fat-soluble vitamin we talked about? Yeah, A, D, E, and K. We talked about D in regards to absorption of calcium and things like that in the endocrine section. Vitamin A is really important for vision. And in fact, if you have a deficiency in vitamin A, especially over a long term, because usually the eyes have the liver has a good store of vitamin A, but if you're over, you're say malnourished for the course of months or something like that, and you lose a lot of your vitamin A, you end up developing night blindness, right? So you're not able to really see things in the dark all that well, or at least worse than you could normally, right? So vitamin A is absolutely required for this. You're going to see different pigments are going to be in the different cones. They're similar to rhodopsin, and again, the signal pathway is going to be basically the same regardless. All right, so what's happening here? And again, I'm not going to have you memorize this whole cycle here, but just know this is where vitamin A is going to be coming in, always known as all-trans retinol. Eventually, it's going to get turned into what we call rhodopsin, and that's our main pigment there. It's going to be located within the rods. So normally what I mentioned is with normal, like say neurons, I mentioned they normally have a resting membrane potential, usually like -70 or so, and then when they want to fire off an action potential, they open up what? Usually, what type of channels? Sodium channels. Yeah, sodium channels are typically going to be opened up, and that allows for that negativity to rise up. It's going to get much more positive, and then you have an action potential. These are like the one cells we're going to talk about that are kind of the opposite of that. It's kind of interesting. working, at least I think they're interesting. But normally what you're going to find that at rest in a sort of dark situation, say we're in the dark, you're going to find that these sodium channels here tend to be open. Okay, so you're going to have these sodium channels that are open. It's allowing for sodium ions to flow in. You're also going to have some potassium channels open here as well. Potassium's here in yellow. It's going to be flowing out. So basically you're having this kind of this current flow that's occurring here. And actually you notice that because we have more sodium flowing in, what do you think the resting membrane potential is? Higher than 70, lower than 70? A little bit higher. It's probably around like -40 or so. So it's a little bit more positive than you see like in say a normal neuronal cell. And again, our sodium potassium pump is still here, kind of chugging away, making sure we maintain that resting membrane potential that's a little bit higher than normal, right there in the rods. So what happens is, remember we talked about cGMP. Remember that we talked about guanosine monophosphate, right? Remember how we talked about cGMP, so cyclic guanosine monophosphate. We talked about that in regards to like smooth muscle contraction, like in the blood vessels. We talked about the enzyme called phosphodiesterase. It can break it down. We talked about sildenafil, Viagra. Anyone? Okay, so if you go back and review that, you would see that cyclic GMP is going to be one of these secondary messenger systems that are useful for the signal transduction within the cell, right? And so one of the things that breaks it down is phosphodiesterase. Phosphodiesterase, at normal, if you have kind of a low light sort of situation, normally you're going to find that rhodopsin really isn't doing it. It's just kind of sitting there. You have lots of cyclic GMP that's around that's keeping these sodium channels open. Okay, normally sodium channels are open in the dark sort of situation. That's fine. These are the rods. That's how they work. Okay, what happens when you actually have light come in? When you have light start to activate this whole process here, what you're going to notice is that these sodium channels close. Okay. Light causes sodium channels to close, and it does that because it's going to cause rhodopsin to activate this protein here, which you don't need to memorize that name. But basically what it is activating is this phosphodiesterase. Phosphodiesterase then cause the cGMP to be inhibited, or to break it down essentially. So it's going to start to break down cGMP, and without this around, these sodium channels close. So that's what happens when you see light. Has anyone heard of a particular side effect, or maybe they've heard of this with like Viagra, someone going blind while on Viagra? Has anyone ever heard of that side effect? You probably don't talk to enough people who are on Viagra, but that is a thing that they say can happen. And that actually makes sense when you think about it, because Viagra, I mentioned, is a phosphodiesterase inhibitor. So imagine, you know, if I had an inhibitor on board and it was affecting the cyclic GMP here, it would be like that light signal never gets turned on. It would be basically I'm in the dark essentially. And so that is something they can have. They have this transient blindness that can occur, and a lot of it is thought to be due to this cyclic GMP not being affected by phosphodiesterase. Again, just a bit of a tangent there. But main thing to note here is that light is going to cause these sodium channels to close. And what do you think it's going to do to the electric potential for the cell? So less positive flowing in now is going to become more negative. Yeah, so now it's going to get more electronegative. It's going to hyperpolarize. Normally when we say we want cells to be stimulated, we want them to have depolarization, right? This is the opposite. We're actually going to have hyperpolarization of these cells. And what that's going to do is eventually allow for communication with some of those other cells we mentioned, those bipolar cells, and then eventually those ganglion cells. So I'll show you more detail on that in a second. But just know when you have light, close the sodium channels, those cells tend to hyperpolarize, they get more negative than they were normally. Okay. All right. So once that occurs, you're going to start to stimulate some of these horizontal cells. These actual horizontal cells are kind of interesting because what they help to do is that lateral inhibition we talked about. So for instance, if I have you know, a lot of light coming into the eye, I want to be able to distinguish between areas of light and dark. And so if all my cells are being bombarded with light all at the same time, you can't really distinguish between a lot of differences there, right? There's no contrast. And so these horizontal cells help provide some of that contrast. They help to cause inhibition of, say, surrounding rods and cones to help try to limit some of that over signaling essentially, so I can see more gradations between light and dark. That's not like an all or none phenomenon. It's much more of a graded sort of response. And then eventually they'll communicate with these bipolar cells, then communicate with the ganglion cells, and then this goes to the optic nerve, right? So then that from the optic nerve goes to the brain. We'll talk about that pathway in just a minute here. So again, it's very important that we have these sodium channels closed. You hyperpolarize those cells, and eventually will stimulate these bipolar and horizontal cells to eventually stimulate the ganglion cells. Okay. And then at this point, it's a normal action potential that can send a signal just like it would, say, if I prick my finger or if I stepped on a nail or something like that, same type of signal once it gets to those ganglion cells. So mentioned there's three types of cones that are available. We have red, green, and blue cones. And again, they're all mainly trying to focus on a certain spectrum of visible light. Again, red cones see one specific set of colors, green sees another, and blue sees a totally different one. Right? Rods are kind of right in the middle there, but they're most closely related to like the green cones from that standpoint. Again, by mixing these colors, you guys remember mixing like primary finger paints? primary colors back in elementary school. Same thing happens in your eyes essentially, right? So again, getting a signal between red and green can kind of give you an orange sort of color, or maybe yellow essentially, depending on how things are kind of mixing there. Okay, so the question is like, what about color blindness? Like, what's happening with those patients who have color blindness? Well, essentially, they're having kind of a deficiency in those cones that are available, and so you can have a deficiency in one type of cone. You can have deficiencies in multiple type of cones. In some cases, it may be a minor deficiency. Some cases, it might be they have none of those cones available, right? And so again, you have gradations of color blindness that occur here. Now, what type of patients might be more prone to color blindness? Usually, male patients are typically more prone to this, and that's because, anyone know why? It's an X-linked trait, right? So again, if I have, and it's a recessive trait. So because of that, if I have dad who's unaffected but mom's a carrier of that gene, when you have kids, you're going to find that you may have kids that are completely unaffected, boys and girls. You may have a girl that's going to be an additional carrier, right? Because again, dad's only providing the one X, mom's providing an X, and may have that. However, the boy is absolutely going to be affected if he gets the affected chromosome from his mom, right? Because he doesn't have an extra X coming from dad to kind of cover it up. So again, that's why you typically see that male patients tend to be more likely to be colorblind due to the fact it's an X-linked recessive trait. Okay. Now you can have varying degrees of color blindness. As I mentioned, you can have, say, loss of red cones. It's called protanopia. I'll show you some pictures here in a second. Loss of green cones is called deuteranopia. This is called red-green color blindness when you have one of these two deficiencies. So again, typically red and green, they have a hard time distinguishing between those colors. There's blue-yellow color blindness, which is called tritanopia. I think it's due to have a deficiency of blue cones. And then there's monochromacy, which is when you have two types of cones, failure in two types of those. That's what we call monochromacy. Things look much more black and white, right? I saw this on Reddit the other day. I thought it was a really good kind of illustration of this. So imagine you have normal vision. You're looking at colored pencils. I apologize for anyone who might be colorblind in the room. I don't mean to draw attention to it by any means, but this is what it might look like to someone who had some of these issues here. So if you're red-green weak, you had protanopia, so again, a deficiency of those red cones, you would have a very hard time distinguishing between these colors. They all kind of look like yellow-greenish. At least to me, they look kind of yellow-greenish. Maybe I'm diagnosing myself with a vision disorder. Who knows? If you had tritanopia, that would be a blue-yellow weakness, so you can kind of tell the distinction between some of the reds here, but again, some of the blues kind of lose a lot of their blues and greens, tend to be tough to distinguish between the two. And then with monochromacy, everything's kind of relatively black and white, essentially, right? So again, if I lost all my cones and I lost the rods, what would your vision be? Then you'd be nothing. You'd just be blind, right, at that point. So again, kind of keep in mind what the distinctions here between these kind of four different sort of categories here. Again, red weak tend to be either a loss of red cones or green cones, so protanopia or deuteranopia, and then loss of blue cones is that tritanopia. So how can you test for that? Well, they have these nice or these nice plates they have. These are called the Ishihara color test. And so again, what's the first number over here? It's actually 92. You guys are all colorblind. I hate to tell you. Just kidding. Yeah, so 74. How about in the next one? 42. Usually these are testing for red-green color blindness. This is typically the more frequent type that you're going to run into. The blue-yellow tends to be less frequent for whatever reason. But yeah, red-green tends to be the more common one. Okay, so looking at the retina, and again, if you're looking at the fovea itself, we mentioned that's kind of the highest concentration of rods that are available, and that's good because that's where we want our picture, that's where we want the main focus to be on the back of the retina. And so what you notice is if you have light coming through, stuff can get in the way. You can have these neurons and things like that kind of blocking the path. With the fovea, you want the absolute most direct path of light to the rods as you can get. And so you notice here they kind of have this partitioning away where the cells are kind of being pulled apart, and basically the light can get right there to the fovea, right there typically to the rods, maybe some cones there, but that's the main thing we're going to be looking at. And so again, works best with nice good light sort of conditions. And then peripheral to that, you may have a little bit more blurriness, but again, in the fovea, that's where your main vision is going to be. The main focus is going to be there, right? Okay. And then we mentioned that neurons that are going to gather at the optic disc. This is going to be our blind spot, and they exit as the optic nerve, which is cranial nerve number 2. And then a lot of blood vessels are going to be entering and leaving here as well, as we mentioned already. All right, so looking at the visual pathway where it's going from there, so we mentioned the cornea to the anterior chamber in the anterior cavity, then go through the pupil, posterior chamber, and the anterior cavity, and the lens. Covered that. And it's going to go back to the retina. We covered that, and then through the rods and cones, and it gets converted into a electrical signal. Is going to be hit up by the horizontal cells, bipolar cells, and then eventually to the ganglion cells. At that point, once we have optic nerve number 2 exiting the eye, what happens there? How do we actually incorporate that into the brain? Essentially, that's what we're going to be looking at here. We're going to be seeing that it's going to get all eventually converge in the occipital lobe in the brain. So we'll look at that pathway here in a little bit more detail in a second. So normally what you're going to see, as far as the visual fields go, we're going to look at how this actually gets transmitted here. So again, when you're looking at something, everything is flipped upside down and then left to right, right? So if you have something that's going to be focused on, and you can kind of go through this on your own, but imagine we're looking at the right eye initially, okay? What you're going to see is that with the right eye, when you're focusing something onto it, that light is going to be crossing over. So say, for instance, you're doing like kind of light coming from the lateral aspect there, right? It's going to be shining through and then focusing on the medial aspect of the nasal aspect of the right eye, okay? Something's going to be coming from the left side. It's going to be then focused back on the lateral side of the retina. That kind of makes sense? This is important to distinguish because, again, we're looking at these neuron tracks back to the occipital lobe. We need to be able to see how these visual fields are being transmitted, because that's going to help us with things like, why do we have two eyes? Why is it useful to have two eyes, especially in the front of our head? Depth perception, binocular vision, right? So again, it's really important that we know how those signals are being transmitted, so that way we can take those two images, which are separate, and kind of fuse them together, right? And you're going to see that these visual fields tend to be transmitted together on the one side of the brain to the other in order to make that picture work, essentially. Okay. On the left side or on the left eye, you're going to see that if something is coming from the lateral aspect, it's going to be traveling and crossing over and then hitting the more nasal or medial side of the retina, and vice versa. If it's coming from the right, it's going to be focusing on the medial side of the retina. Okay. That's important because when you're looking at this and you can follow the lines here, you'll see that anything that kind of gets focused onto the left side of these retinas here, kind of notice how they follow. So notice how they're tracking here. So again, you notice if I'm sending light and I'm focusing it here on the lateral side of the retina here in the left eye, it's going to be traveling along. It's going to travel along this optic nerve. And then where do you notice it ending up? On the left side of the brain, right? So again, that one stays on the same side of the brain. If you're looking at this blue line here, so again, that same light coming from the right side is going to be focused on here. In this case, on the right eye, it's only going to be on the medial aspect, the nasal aspect of the retina. It's going to be traveling along, and then what do you notice about it? Crosses over, right? So again, that vision, that visual field is going to cross over and then end up in the same place in the occipital lobe as the left eye, right? On the flip side of that, if I have something that's being focused onto the lateral aspect of the right retina, that's going to travel along, and then where do you notice it ending up? Right side of the brain, good. And then something that is being shown onto the medial aspect of the left retina is going to be coming along, and then you notice it crosses over and then ends up there, right? So again, all is going to be focused through the thalamus and then eventually back to the occipital lobe of the brain. So it's good to know if I'm shining a light where it's shining on, where is it going to end up in the brain? So keeping those visual fields together, so that way you know that, okay, well, when I need to fuse these two visions together, I can actually get that binocular vision that actually works out. So again, that optic chiasm this is where actually having that crossing over occur for some of those nerves, and so then it's going to be going to the lateral geniculate, the nucleus of the thalamus, and then it goes back to the primary visual cortex. I mentioned that's in the occipital lobe of the brain there. And so this will become important because when we're looking at the CNS function later on in this class, we're going to see how we can incorporate all this information coming from the occipital lobe and factor that in with like things like the somatosensory cortex, focus it in with like the vestibular apparatus, all of that to make sure that what we're seeing matches up with what's going on with everything else in the body, and we don't fall on our face, for instance. Okay, see here, occipital lobe is where our primary visual information is going to be entering into the CNS, essentially, or be terminating within the CNS. Again, this picture again shows the same sort of thing here. How if you're focusing something on the medial aspect of the left retina, it's going to come along, it's going to stay along the left side of the brain, end up here. Similarly, things are going to be shown on the medial aspect of the right retina is going to be ending up in the same place. It crosses over that optic chiasm there, right? And then you can look here, if you look at the way the visual cortex is going to be kind of delineated here. Again, the most neurons are going to be here in the primary visual cortex, and this is going to be where the macula is, right, where the fovea is, the primary vision center. And then as you get kind of further degrees away, you notice that your vision kind of gets fuzzier and fuzzier. You kind of have less neurons that are kind of associated with that. And that makes sense, though, because again, we want to focus on the primary focal point there. And then from there, you can kind of send it over to other areas of the brain. We're going to cover this more in the CNS section at the end of the class, so kind of keep that in the back of your mind. Literally, because it's the occipital lobe. Anyway, so how do we move the eye? How do we get that moving there? So we're going to have cranial nerve number. Okay, so there's a couple we're going to see. Cranial nerve number 3 is going to be one of the big ones that helps to move a lot of this, but there's going to be a few more that are going to be involved here. So 6 extrinsic eye muscles. These are going to be the main things that are going to be moving our eye around. And so anyone that has kind of a weird eye thing, like I know there's like some movies out there that have like needles going into eyes, like this stuff kind of weirds some people out. But looking at this, we have the superior rectus muscle. Notice right here. You're going to have the inferior rectus, located down here on the inferior side of the eye. We're going to have the lateral rectus, located on either on the outside of the eye there. Medial rectus, you see here. And then we're going to have the superior oblique. Kind of notice right here. Here's the trochlea it's going to be helping to interact with. And then the inferior oblique, you can see it kind of looping around here. Okay. So again, how do we control that? Because again, this is where we're going to be looking at how we can move our eye around to kind of either if we're trying to fixate on something, either voluntary or involuntary, all that's going to become important with these muscles. So again, just another picture kind of showing the same thing. Main thing to note is that cranial nerve number 3 is going to be really important for moving the majority of these muscles. About 4 out of 6 are going to be involved with this. So again, in the next slide, I'll kind of show this as well. But also cranial nerve number 6 and 3, I'm sorry, cranial nerve 6 and 4 are also going to be involved here as well. So should this actual written out form, so the superior rectus is going to be cranial nerve number 3, along with the inferior rectus, along with the medial rectus and the inferior oblique are all going to be cranial nerve number 3. Whereas cranial nerve number 6 is going to be responsible for the lateral rectus, and then superior oblique is going to be cranial nerve number 4. Okay, I'm sorry you have to memorize that, but it's good to know. Because again, if I have a deficiency in one of these nerves, guess what? Eye movement is going to be pretty drastically affected there. So look at some ways we can actually test for this in just a minute here. Cranial nerve number 3 is also responsible for moving the eyelid. So again, that's that levator palpebrae superioris is going to be associated with cranial nerve number 3. So looking at the actual actions of what's going on here. So for instance, the superior rectus is going to be able to move the eye. Which direction do you think? Mostly upward, but it's also going to be able to move it laterally as well. The inferior rectus should move the eye mostly down, right, and also a little bit lateral. Lateral rectus, as you might imagine, will abduct the eye, right, so kind of move it away. Medial rectus should adduct the eye, so you can move it closer. I always have a hard time whenever I'm like in the gym and I'm looking at the thigh machine. I'm like, is this one the abductor or the adductor? And I think abductor. I think of the movie Taken for whatever reason. I'm taking the legs away. Abductor. I don't know why I made the association, but it helps me. So maybe it'll help you too. But the adductor is moving things closer away, right? So maybe the end of the movie would be the adductor portion. I don't know. Anywho. So there's that. Medial rectus again is going to adduct the eyes, so move it in closer to the medial aspect there. Superior oblique tends to move the eye downward and medial. So if you're looking at superior rectus, if you actually were trying to test that superior oblique, you're going to see that it actually moves the eye downward because you imagine pulling that muscle that direction, it'll be more downward and medial. And then the inferior oblique is going to be moving the eye upward and more medial. Okay. Basic movements of the eyes. In those 6 muscles, 3 cranial nerves are going to be responsible for the majority of that, right? All right, so looking at actual eye movement itself, like how do we, utilize that, all those muscles and all the innervation actually to look at something? How do we focus on something? And so it's called fixation, when you're deciding to fixate on something. Some of you may be fixating on me. Most are probably looking at some website, I imagine. Who knows? I'm going to assume it's just me you're fixating on. And so there's going to be what we call voluntary fixation versus involuntary. Voluntary would be what? So voluntary is I'm choosing to look at this, right? I'm choosing to look at something. Involuntary is going to be allows us to maintain that fixation, right? So again, you think, okay, I want to look at this, say this pin right here, and then the involuntary fixation helps my eyes to keep maintaining. I don't have to consciously think about it necessarily. That allows me to maintain that fixation. And so the eye has natural kind of movements to itself. It has a lot of kind of drifting and snapping back in order to make sure that we keep the main focus on to which part of the retina. The fovea, we want to make sure we keep everything on the fovea there. So it's kind of interesting as you're looking at this movement of the eye, and this person's kind of illustrating this. Imagine you have a voluntary movement of fixation to the eye, right? So I'm deciding, okay, I want to look at this, and now you're noticing the movement. So basically the dotted lines are going to be kind of this involuntary movement of the eye sort of drifting, and then when it drifts off of the fovea, then the eye automatically wants to shoot back, and then we'll get it back right onto the fovea, right? It focuses that image back there, because again, that's where our the majority of our visual acuity is going to be coming from, right there. And then it's going to drift again, and then kind of snaps back. I'm trying to see where it's at. Snaps over here, and then drifts again, snaps. So again, that's why if you're like reading something, you're looking at someone kind of you see their eye kind of moving on its own. It seems like that's that involuntary fixation, trying to keep things on the fovea. Okay. There's also what we call saccadic movement, or maybe saccadic movement. Anyone ever heard of that? So basically, if you're like, you notice like you're in a car and you're looking at things out the window, like do your eyes just stay on one focal point and just kind of keep going on, or do they kind of jump from object to object? That's that saccadic sort of movement where you're focusing on, like, I'm looking at this tree, now I'm looking at this tree as it goes by very quickly. The same thing happens when you're like reading a book or something. You notice like your eyes aren't really moving too drastic when you're reading from left to right, but you'll see that if you look at someone reading something stationary, that they're going to be, you see their eyes kind of have that saccadic movement across, and that's in order to make sure they're kind of focusing on the right thing. So that's what that's referring to. And again, you can see how these nerves are kind of working by looking at the voluntary fixation area, which is typically up in the frontal cortex. That's where we're making a lot of like our executive judgments on what we want to do voluntarily. Whereas involuntary fixation is going to be mostly located within the occipital area, which makes sense because a lot of our visual information is coming in there. That involuntary sort of signals to try to keep whatever we're fixated on right in the middle is going to be kind of mediated through that. And again, we don't have to think about that in a lot of cases. So any questions on vision? Yes, sir.
Would be just sum it up would be like keeping a fixed point for an image to image.
Basically, it's like it's French for jerk. I saw. So if you ever want to call someone a saccade, it could be a sick French burn, I guess. But basically, it means like when you see the eye jerking, so when it's moving from object to fixation. So again, the best thing you think about is like when you're in a car and you're looking at things out the window, right? So your eyes don't stay in one point typically. It typically will jump from point to point, usually something you're trying to fixate on, right? Because the eyes, typically, they want to keep fixated on something because otherwise things keep blurring by. That's usually when you end up seeing, you have some issues like, the vestibular apparatus, and you see some nausea, vomiting. Kind of like there's a cool video, I don't know if you've ever seen this, but they show these two dancers, and it shows this guy who is spinning this woman around, and if you look at her head, it's kind of crazy because her head keeps snapping back to the same place every time she spins, but by doing that, she's able to stay fixated on a single point, and it actually helps to prevent a lot of the dizziness that comes about from spinning someone around. Whereas if I just kind of spin around on my own, I'm probably not going to be fixated on much, and then everything kind of gets all kind of wonky there. So if you ever see that video, it's kind of interesting. But anywho, so any other questions on vision? All right, so moving on. Next, we have the ear. How much time have I left? Yeah, 8 minutes. Perfect. So let's get started on here. So the ear's good for hearing. Don't stick things in them. Little kids like to do that, and then it's no fun. Don't let bugs infest there. Also not a good idea. There's been some pretty nasty videos out there I've seen. But anyway, yeah, so we're going to see that the ear's good for both hearing, and it's also going to be really where our vestibular apparatus is going to be lying. Is what helps us to maintain balance, helps us to be able to move appropriately, and helps to give us a lot of the good spatial awareness or awareness of movement going on within the body. So we're going to notice that cranial nerve number 8 is going to be the vestibular cochlear nerve, which is good. So that's going to be transmitting signals about sound that we're hearing, and also going to be transmitting signals from the vestibular apparatus and sending information to the brain about movement and whatnot. So, and you're going to see how we'll kind of divvy this up a little bit, but mainly the cochlea is going to be mainly responsible for what? Hearing is going to be the big thing here, and then we're going to notice here this is our vestibular apparatus, and with our things like our semilunar canals and our utricles and saccules and all the good stuff, we're going to get into detail on here in a second. So, hearing and equilibrium, again, these are the main things we're talking about in regards to the ear. So, looking at the inner ear, we're going to notice our vestibular apparatus is where we're going to have these semicircular canals. You kind of notice them here, and I have 3 of these typically. And what do you notice about the orientation? They're all oriented in a different direction, essentially, and that's good because it helps us with being able to detect movement in different planes, essentially, right? Whether I'm moving my head side to side, up to down, side to side like that. You need to be able to detect movement in those different fields, and so that's what their semicircular canals are going to be good for. There's also going to be what we call the saccule, and then the utricle. These are going to be good for detecting linear acceleration, either vertically or horizontally, as we'll see. They each have a special function here in a minute. And then there's also going to be what we call the otoliths. They're going to be important for function of the utricles and saccules in a second here. So again, these are just the ones we're going to talk about in more detail in a minute here. And then the cochlea, very specialized for hearing. I'm sure you've heard of like cochlear implants and things like that that help to kind of make up for any deficiencies a patient might have on their own. We'll talk about how that cochlea actually works. So, better picture of this, the vestibular apparatus are semicircular canals. Here we're going to have the vestibular nerves coming in and picking up signals from all of this, and we're going to have the utricle and saccule as well. It's going to help us with that linear acceleration. All right, so again, vestibular apparatus helps us to provide a sense of equilibrium. It's going to be located within the inner ears we saw, and then that semicircular canal is good for rotational acceleration, utricle, saccule, and then the otoliths that are associated with those are going to be good for linear acceleration. So either up and down or forward and backward, essentially. So the inner ear itself is going to be consisting of this bony labyrinth. It's going to be kind of surrounding the cochlea and the vestibular apparatus. And then what you're going to find is that between this bony labyrinth and then this membranous labyrinth, where the actual tissue itself resides that helps us with equilibrium, we're going to find that there's going to be what we call this perilymph. Okay, perilymph is a fluid. It's going to be located there. It's going to be basically, we'll see how it kind of functions in conjunction with the rest of this, but there's perilymph, and then the opposite of that is going to be what's actually within the membranous labyrinth. That's called endolymph. Okay, so these two have to communicate with one another. We'll see how they do that, but these two need to be maintained within equilibrium, as you'll see. Okay, so again, you have 3 different semicircular canals: anterior, posterior, and lateral. And then we're going to see these ampullae are where the actual information is going to be sent, or the actual information is detected, I guess I should say, about the rotational acceleration. And then the sacral and utricle are going to be good for that linear acceleration. Okay, so again, these project in 3 different planes, so they detect rotation. Again, you don't need to memorize necessarily which way each one is detecting motion, but just know that these are going to be good for rotational sort of acceleration there. Each canal is going to be itself filled with endolymph, right? So within the membranous labyrinth, you're going to see that endolymph. On the outside of it would be the what? The perilymph, right? It's going to be outside of that, and then outside of that would just be bone, essentially. Okay, so each canal is filled with an ampulla. Okay, and so you can kind of see the ampulla here. Here's one of the semicircular canals kind of taken out from the rest of them. And so you're going to have this ampulla. And you kind of notice you have these hair cells here. Okay, so hair cells are very important. You're going to have these stereocilia, which are located here. And then each one of these hair cells has also what we call a kinocilia. Okay, talk about their functions here in just a second. But the main thing you're going to notice here is that as you have some sort of rotation, you're going to have this endolymph in here. And what do you think it's going to do? Is it stay static all the time? It moves, right? So it moves around based on which way you're rotating. And by doing that, you're going to cause fluid to flow across this ampulla. And it's going to cause this to shift one direction or the other, right? And by doing one direction or the other, you're going to cause some channels to open up and either cause an action potential to occur or inhibit action potentials from happening. And so based on whether you're having inhibition or stimulation of those, that sends a signal on cranial nerve number 8. Good, and that sends a signal to the brain saying, hey, we're having some rotational acceleration in this direction or the other. And again, your 2 vestibular apparatus are communicating with one another. And so again, on one side you may have inhibition, on the opposite side you should have stimulation, right? Because again, they're rotating in opposite directions at that point. Just a little bit closer picture here. Again, this couple is actually going to be kind of secured to the ampulla here, but as the fluid flows across, it can go in one direction versus the other. And this kinocilia is going to be kind of the major mover here. So we're going to see the stereocilia are going to be attached to that and kind of go along with it, essentially, right? And you can see here, these hair cells are then communicating these afferents of the vestibular nerve, and then all kind of conjoined together, along with afferents coming from the other semicircular canals, and also the utricle and the sacule and all that. So as you have a person changing head position, you can see here that fluid is going to cause us to shift, and that can either cause, and again, you can see it right here, at baseline, they're going to have some level of action potentials coming out, but when you have that rotation there, you're going to notice that the action potentials are going to speed up really quick. As they slow down that rotation, they're going to stop, and you'll have kind of a period of hyperpolarization, and then it's going to kind of go back down to its baseline. So as the person's moving their head, you're going to start to see that shift occur, and then as they stop, it's going to kind of go back down to baseline, right? Kind of go back to resting at that point. And that's when the head is detecting, hey, I've stopped that rotational acceleration, essentially. And again, the endolymph itself is really high in potassium. So I mentioned other cells are typically like that salt wrap banana. This is more like a very high potassium concentration on the outside of the cell. And then as those hair cells, they pull, it's going to open up those potassium channels, allow it to flow in. And as those cells become more positive, that triggers off an action potential. Or if it's going the other direction and it's closing off more channels, then that will cause the cell to be what? It'll be hyperpolarized. Yeah, it's going to be less likely to have slower action potentials being signaled. And then again, each of those changes, whether it's more or fewer action potentials, sends a signal to the brain saying, hey, something's going on here, essentially. That kind of makes sense? Okay. You kind of see here, if you're looking at rest, again, every one of these hair cells is going to have kind of a baseline action potential being sent out. So again, some of these potassium channels will be open. However, when you pull it one direction, say for instance you pull the kinocilia this way, you're going to see that it's going to be opening up potassium channels. You're going to see a lot more action potentials occurring. It's stimulated. You pull the other direction, you close off those channels, and now it's going to be inhibited. Still some action potentials, but much fewer than you would see if it was at rest or if it was being pulled the opposite direction. Both of these are sending a signal saying, hey, we're having movement in one direction or the other. Okay. And by coordinating with the other vestibular apparatus, you're able to get that information and get a much more kind of full picture of what the head's doing, essentially. Okay, again, this is saying the same thing. Basically, when the potassium comes in, it causes a depolarization that allows calcium to flow in. That calcium then causes excretion of certain neurotransmitters, things like glutamate, that sends that signal up through cranial nerve 8 back to the brain. Okay, and then the potassium is going to be effluxed back into the perilymph, and then can eventually be recycled back into the endolymph there. Okay, so potassium is a big mover here, causing active potentials, not sodium, as opposed to most other cells we've talked about before. Okay, so any questions on that so far? I will stop here. I don't have too many more slides to go, but we'll finish up next time, and then we'll start the review, and then you guys will have your test. Any questions? All right, see you guys next week.